For the kind introduction and the invitation to speak here. Bill had asked me what would I like to talk about regarding ECMO to a perfusion conference, and I was like, well, UNOS just gave us a lot of new information about or new guidance on heart allocation. We're kind of struggling with the right way to apply that at our institution. Why not discuss that in this setting also? So we're going to name the talk as VA-ECMO as bridge to heart transplant. Is that a bridge too far? So I'll go ahead and give you the short answer, and I'm going to say no. So that's it. So disclosures real quick. I'm a consultant with A-Line Technologies, and some of the devices mentioned in this talk are going to be used in an off-label fashion. So talk to the right people. Transplant off of ECMO maybe seems like walking on this bridge into the unknown. Maybe not for everybody in here. Just maybe show of hands. Who all is doing heart transplant at their program right now? Pretty robust. Good. So here's the new status 1, status 2 heart allocation algorithm for adults. So what was previously status 1A would be patients admitted to the hospital with a PA catheter on 2 inotropes. That's now status 3. Status 1 is relegated entirely to VA-ECMO, non-dischargeable, surgically implanted, non-endovascular biventricular support devices, so surgical BIVADs, or a durable device with life-threatening ventricular arrhythmias. That's your only pathway to status 1 now. Status 2s are going to be dischargeable, durable MCS devices, balloon pumps, percutaneous endovascular devices such as Impellas, and stable malfunction of MCS devices. So the question is this an appropriate allocation paradigm? I would say this is well studied both domestically and internationally, and there's good data behind this. So let's review that, and I'll go ahead and give the background that every study that's come out on this of any substantive size is retrospective registry or database review. So the first one that we're going to look at, this is a U.S. study. Dr. Ouyang's group looked at just the incidence of MCS support, temporary MCS support in heart transplantations. How did that impact outcomes? So, the reason for looking at this was when UNOS was first proposing the change in allocation algorithm. Previously, patients that were status 1A, you had multiple pathways to get there with very disparate levels of sickness in that group. So a patient that's sitting up in an ICU or a heavily monitored setting with inotropes and a PA catheter in place, sitting up watching TV, eating breakfast with end-stage heart failure well controlled, they had the same high urgency status on the allocation list as a patient that is on femoral percutaneous VA-ECMO, same status as a patient who's dependent on percutaneous VAD. And you have a very disparate group with very different mortality in a 6-month period. So what this group did, they reviewed the National Inpatient Sample Database, which is a good sampling of small, medium, large hospitals. They pull ICD-9 coding and give hospital outcome measures, but there's no long-term follow-up. They classified temporary MCS devices as balloon pump, percutaneous VADs, and ECMO. So they reviewed all patients undergoing heart transplant from 98 to 2014. They excluded unknown dates, or if it was unclear if MCS devices were implanted pre or post transplant. But then they got a nice collection of all comorbid conditions and in-hospital complications, and all of that was based off of ICD-9 codes. Now, this may be a little difficult to read here, but this is going to be just the baseline characteristics of all patients that they examined. And you have similar distributions of age, sex, socioeconomic status, hospital size. So a very nicely homogeneous mixture in each group. Looking at the patients who did and did not receive temporary MCS devices, there was an increased incidence of type 2 diabetes, hypertension, and pre-existing renal dysfunction in the cohort that did not receive temporary MCS. And if you think about that, that makes sense. The patients who are going to make it to elective heart transplant are not going to be ones who crashed. These are not crash and burn patients. These are patients who have long-standing heart failure that has slowly progressed over time. They've been in the pipeline. They've done all the things they were supposed to do. They've had disease progression despite that, and now they're listed for transplant. They get the call, they come in, they get surgery. Patients who are going to be on these devices more likely came in with ischemic disease or some other major insult that put them in a severely decompensated state. So I'd say there's more chronicity of disease in the non-MCS group by these registry and database reviews. And this is just a look at incidence of MCS devices pre-transplant in this era. So the blue is the use of balloon pump, the red is ECMO, and then you start to see this inflection around 2007 with percutaneous VADs, and that kind of bears out with when you could start getting reimbursed for them. So let's look at mortality. And what they did was to break down a so-called early versus modern era for temporary MCS in transplantation. So looking at from 1998 to 2006 is a so-called early era, modern from 2007 to 2014. So if we look at mortality in patients who received acute circulatory support, you had about a 14.3% mortality versus 7.5% for the unsupported group. Into the modern era, the mortality is equivalent with a trend towards lower mortality in the acute circulatory support group. I'll give a caveat that no other study has shown that relationship of mortality. And there's some biases in this that we can get into in a minute. The other thing to look at is the degree of acute organ failure in these patients. On the left here, you can see that patients who required acute circulatory support, non-surprisingly, had more end organ dysfunction than patients who were going for elective heart transplant. And that bears out into the modern era as well, with a high preponderance of renal dysfunction, respiratory failure, and liver dysfunction. Also, interestingly, they demonstrated that there was a greater preponderance of that in both groups studied. So we're transplanting sicker patients by this and getting better outcomes. But what do we make of that? Are we doing a better job of caring for them, or are we doing a better job of recording that? Difficult to say from here. So caveats to this study. Mortality in the post-transplant groups seems to converge into the modern era, so patients who received mechanical circulatory support versus those who did not, which is reassuring, and I think this paper was one of the supporting studies leading to the change in UNOS allocation with hearts. I think that the other thing that they looked at was an increase in complications in the temporary MCS group. So you had complications defining mortality in that group as well. Number of comorbid medical conditions was a predictor for mortality in these patients. Increasing age was associated but not directly correlated to mortality. But all in all, you had an increased length of stay that was not statistically significant. A lot of these patients are in the hospital for a prolonged period of time, and it's really hard to predict who's going to be there and who's not. The major difference here that was seen was the increased incidence of sepsis, bleeding complications, and need for repeat surgical procedures, most typically re-exploration of the chest. And something that I found the most interesting was that the duration of the temporary mechanical circulatory support did not independently affect mortality. So if you were stably supported on a device without significant complication, it didn't matter how long you were on it with regard to your mortality. So all of that's really good information, but it's hard to take any major decisions from that, right? So there's no patient data, there's no data on patient or graft survival after discharge. We just know that those patients survived to discharge. We don't know what their incidence of graft dysfunction was. Were they having increased incidence of rejection? There's no data on patients that were listed for transplant on a device and were either delisted, received a durable device, or died. So there's a major selection bias here because we're leaving out all of the bad outcomes that never made it to surgery, and there's no hemodynamic data in this study. So how well did we do with unloading the right and left ventricle? What was the fluid status? What was perfusion pressure? All of those things are important. I think things that we need to have a better handle on with understanding how these patients are going to do when we take them from ECMO specifically to the OR for transplantation. So this paper followed up shortly after, also in the Journal of Heart-Lung Transplantation, and they did a UNOS registry review, which gives a little more robust information with a smaller data set, but over a similar period of time, from I believe 1998 to 2014, they identified 157 patients from the UNOS registry that were supported with ECMO with a male preponderance, mean age of 46. 70 of those patients died during the follow-up period. The follow-up period was roughly 6 months. 43 of those 70 died during the first 30 days after heart transplant. So we're seeing here, and we'll see this borne out in a couple of subsequent studies, there's a high mortality cost that's been demonstrated early, both pre-transplant and in the 30 to 90 days after transplant. Interestingly enough, of the patients who survived that first 30 days post-operatively, they have pretty acceptable one-year outcomes, with an 82.3% expected survival rate at 1 year and 76.2% at 5 years. So they really come up on the curve nicely once you get them out of that acute phase. So what were the factors associated with their early mortality? So history of renal insufficiency, which they defined as GFR less than 45 or being on dialysis. Just a history of mechanical ventilation. So not going to the OR already intubated, but just having been intubated. And the two of those were synergistic. So at 1 year, you had a 29.4% and a 12.5% 30-day and 1 year survival in the group with those, versus a 78.7 and 71% at 30 days and 1 year in the group that did not have that. So this is a major impact, and coming from the OR, you don't always get to see that. But this is not an insignificant number of patients with heart failure that end up on ECMO listed for transplant and have some degree of renal dysfunction, whether they continue to need some type of renal replacement therapy or just had it transiently. It's a big morbidity with a big mortality impact from what we're seeing. So I would say here that the transplant teams in Europe are probably a little more proactive with transplanting off of ECMO. And so we can see here in the Journal of Transplantation, very nice study from France, and they they reviewed the Crystal database, which is their UNOS equivalent. And so what they did was they pulled all patients listed for single organ heart transplant between January 1st, 2010 and December 31st, 2011. So that's 866 patients, 80 of them on VA-ECMO at time of listing, 700 without any MCS altogether, 60 with a durable device, 23 with a balloon pump. And we just kind of see that in more graphical form there. So again here, differences between the groups. You have a very similar distribution of sex and age. Primary diagnoses were actually inverted between the two groups. So patients who required some type of device had a greater preponderance of ischemic cardiomyopathy. Patients who did not had a greater preponderance of a dilated cardiomyopathy. And again, that goes back to the point we saw from the first study with chronicity of disease seeming to be more associated with elective heart transplant rather than acute ischemic insults. Study patients had a higher rate of mechanical ventilation, dialysis, and receiving inpatient inotropic support. And patients with the control patients who didn't receive support, had higher rates of diabetes too, having ICDs placed, and being at home at the time of listing. Obviously, we're not sending patients home on VA-ECMO, even in France. So, was there any difference between donors here? This to me is interesting. So you have a similar distribution of sex and age in both groups in the donor organs, but fewer grafts with less than 2 hour ischemic times in the study group. I think there's a lot of data to dig out there, because when you get into the world of transplant, you have two patients really that you're taking care of. You have the graft and the recipient, and you know, they are not independent of one another. So you have a trend towards greater ischemic time in donor organs that go into patients on an MCS device. There's a lot of things that could introduce that into the discussion. You know, these patients are more likely to bleed on a device when they go to the OR. Perhaps a more difficult bloody operation to explant the native organ. Outside of that, transport times for recipient or for grafts in Europe should be pretty quick. So I think that explantation of the recipient needs to be taken more into consideration here. But again, that's just difficulty of transplanting a sicker population. So looking at the outcomes. So 1 year survival in the study group, 52%, versus the comparison group, 72%, which was statistically significant. Transplant off of VA-ECMO associated with lower mortality in study group patients. So some statistical gymnastics here, but what they did demonstrate was, so patients on VA-ECMO who go for transplant, even though they have such a high mortality rate, that was still the treatment of choice for them for survival. So survival, greater chance of survival with transplant, even with a high mortality cost. Age greater than 50 was associated with higher 1 year mortalities. Lower GFR and higher serum bilirubin were associated with higher 1 year mortalities. And of the 80 patients that were on VA-ECMO at the time of listing, there were 46 still on ECMO at the time of transplant, 9 that were so-called bridge-to-bridge who received a durable MCS device prior to transplantation. 25 were not transplanted, 18 died, 3 were delisted for worsening, 4 were delisted for improvement. So, you have to take a lot of this with a large grain of salt. What's the most appropriate intervention on these patients? Some of these people maybe would do better with a durable MCS device. Some of them, again, in the so-called bridge-to-bridge. How do we define that from the data? Very hard to say. LVAD explant to transplantation is not a little surgery, but it still has good, nicely demonstrated mortality that's not dissimilar to elective redo chest, heart transplant in a non-device patient. Interestingly enough, subsequent to this data set being collected, the French transplanting agencies did not prioritize listed patients with GFRs less than 40. So they've already recognized that a low GFR is going to negatively impact mortality, and they do not grant them high urgent status with a low GFR anymore. So this Spanish registry is to date the largest patient population, or largest data set of patients published, and a very elegant study. So the ACIS-TC study, so it's a retrospective registry review. All of these are retrospective analyses. And again, single organ, high urgency, no redo transplantation included. Study period from January 1st, 2010 to December 31st, 2015. And we're looking at pre and post-transplant survival and adverse clinical events. And they're looking at the entire cohort, and then they do subgroup analysis by modality, looking at temporary LVAD, temporary BiVAD, or VA-ECMO. So we have 169 patients, which made up the majority of the temporary MCS population, 70 with a temporary VAD, majority of them being surgically placed, a few percutaneous endovascular temporary VADs, and then 52 with surgical BiVADs by majority. A little difficult to see, but again, just to reiterate, these are very similar patient populations in terms of demographics. Interestingly enough, the VA-ECMO patients make up a greater preponderance of INTERMAX 1 and INTERMAX 2 by population. Almost 100% of the ECMO patients were INTERMAX 1 and 2. At best, you have 75% of that in the temporary LVAD, temporary BiVAD group. Days on support to listing was only a mean of 3 in the VA-ECMO group, which is less than half of what the other groups were. And the authors go back to discuss this at the end in the discussion on the paper, because there's a mentality that the degree of temporariness of the device should drive in us to list and transplant patients faster, so we can get rid of the device, which is a little contrary to what we see in other papers, where it appears that complication-free ECMO and other temporary MCS device support, complication-free support has no bearing on mortality. So if we should be striving, perhaps, to deliver as complication-free support as possible to rehabilitate these patients completely or near completely before going to the operating room. So here's their very complex paradigm of who went where. Majority as I outlined on the previous slide. So here's the competing outcomes slide here. So if you follow the blue line from the top to alive on support to off support to the bottom right, we see that almost 75% of patients in this cohort were successfully transplanted. A little less than 25% are deceased, and then a small percentage were successfully weaned from their device. So here's 1 year, Kaplan-Meier 1 year outcomes for each group by device type. So by temporary LVAD, you have a very nice survival curve. 1 year survival roughly 75%. Temporary BiVAD and VA-ECMO have very similar outcome curves or mortality curves with survival right around 52-53%. not surprising outcomes here. If you go back and do a finer review of the baseline characteristics of all these patients, the patients who received temporary BiVads, patients who received VA-ECMO as their support modality were sicker, had more medical comorbid conditions, had an increased preponderance of patients receiving dialysis, mechanical ventilation, liver dysfunction. All of these are a sicker cohort of patient. So even the authors here think that perhaps they're transplanting these patients too soon, listing these patients too soon. Spain is one of the models for quick organ procurement. They're very efficient and culturally perhaps more open than in the U.S. In terms of the population being open to the idea of organ donation. So they don't typically have long wait times. So when you list patients, you get organs pretty quickly. Going forward with that, maybe it's better to spend more time to adequately unload the left ventricle, to correct coagulopathies, to get them out of pulmonary edema. All of those things are important as well. So they continue to go on and look at major adverse clinical events. So they define that as device dysfunction, stroke, bleeding, infection. There was no statistical difference among modalities of support. There was risk of there was roughly 50 complications per 1,000 device days studied. Patients who experienced these had lower rates of successful transplantation. Patients who did, and this is to me one of the biggest things to take away from that. Patients who did not experience a major adverse clinical event were successfully transplanted 92.3% of the time. You had a 4-fold increased risk of death during support with these, lower survival from listing to discharge, and lower 1-year survival by almost 15%. So what was the lessons from this? There's a high early mortality cost. To me, this says there's a lot of modifiability. We're identifying risk factors, but how do we modify them, and does it matter if we modify them? We don't know. VA-ECMO and BiVAD patients were sicker than the temporary LVAD patients at the time of listing. So is one modality better than the other? Hard to say. You're not making an apples to apples comparison here. And you can't have an expectation for, to me, this is the other big takeaway. You cannot have the expectation for similar outcomes from this cohort of patients as you see in elective heart transplantation. The majority of the patients the majority of ECMO patients in this study were Intermax 1 or Intermax 2. So lots of unanswered questions here. We have multiple data sets that tell us VA-ECMO as bridge to transplant is feasible, but with higher associated mortality than elective. Talking about VV-ECMO for ARDS, VA-ECMO for acute cardiogenic shock related to acute MI, all of these things, it's always patient selection, patient selection, patient selection, and then early intervention after that. But we don't have clear criteria yet to know, do we wait until they develop organ dysfunction and then intervene? Do we want to figure out ways to identify these people before they have multi-system organ dysfunction? That needs to be work that's ongoing. Signals in the data tell us, again, duration of ECMO support does not directly impact mortality. So if we can ensure high quality MCS being delivered without complications, we can achieve better outcomes. And this has been borne out in other studies that we didn't have time to get into, but it's been ELSO registry reviews have demonstrated that centers who do more ECMO deliver better ECMO with better outcomes. So we need to be focusing these types of patients into centers who do high volume ECMO, high volume transplant that are experienced in that practice. So basically, it's the the favorite line at the end of the study, which is more studies needed. So conclusion, last thing I'd leave you with, University of Maryland published a really nice data set, or their experience with ambulating femorally cannulated patients. Who here's done that before? Okay, cool. They have two papers. This one is a mix of VV, dual site VV and femoral VA-ECMO. And they had a very nice experience, 167 patients with 0 major adverse events. Local minimal bleeding, and that's all. They're practicing in a financially austere environment. They don't spend the money for the dual lumen bicaval cannula, so they femorojugular cannulate for all of their VV-ECMO patients. They have the physical therapist, once they're cleared to do PT, they flex the hip for the leg that's cannulated to 90 degrees. If there's no interruption of flow, patient discomfort, or bleeding, they sit the patient on the side of the bed, stand them up, and walk them. That's maybe a little bolder than our practice. We use a bed that goes from a supine to standing position without flexing the hips. But it's very clear that patients who received robust physical therapy on ECMO not only tolerated it, but they rehabbed faster. Once they were off of ECMO, their rapidity to achieve independent or near independent exercise status was far greater than the ones who didn't receive PT. So we need to be applying this modality of robust multidisciplinary care to rehab the patient from a physical standpoint as well as an end organ standpoint, and look at that for these patients as well. And just to share, this is a patient from our institution who ultimately went for durable VAB, but he's up, strong, walking with a walker, and a lot of extra attention to his cannulas. So maybe it's not the scary bridge from the beginning. Maybe it's a pretty bridge with a nice destination in the background, and we just have to figure out how to get through the fog. So, do we have time for questions, or come back later?